Okay, a couple of things we have to talk about in regards to the mechanical system of the heart. We have something called stroke volume. Stroke volume is the amount of blood ejected with each heartbeat. We also have cardiac output, which is the amount of blood pumped by each ventricle in 1 minute. You do have a normal cardiac output of 4 to 8 liters per minute. And then you have a cardiac index. This is actually the cardiac output divided by the body surface area. You have stroke volume and heart rate and cardiac output, which plays an important key in the factors that you see on your screen: preload, contractility, and afterload. So you essentially have a little formula in regards to cardiac output. You have that cardiac output equals stroke volume times the heart rate. When we talk about preload, we are talking about the stretch that is placed on the myocardial fibers. So think preload, think stretch. When we think of contractility, we actually think about it being increased by epinephrine and norepinephrine. The increasing contractility actually increases your stroke volume, which will increase ventricular emptying. When we have afterload, that's actually the resistance that is placed on the left ventricle in regard to pumping. So afterload is affected by the size of the ventricle, wall tension, and blood pressure. So if you have an elevated blood pressure, the ventricles must increase in order to inject the blood. They need to meet the demand. Think of the heart as a pump, as a car motor. It has to function efficiently and appropriately, and if something breaks down, then it doesn't complete the job that it is supposed to complete or maintain. So on this slide, we're going to talk about the chemoreceptors. Chemoreceptors are located in the aortic and carotid bodies of the medulla. They cause changes in the respiratory rate and blood pressure, and they respond to an increased arterial CO2 pressure, which is called hypercapnia. And it also will have a decreased plasma pH. Remember, the decreased plasma pH is acidosis. And an arterial O2 pressure, which is called hypoxia. With the chemoreceptors in the medulla, they're triggered and they stimulate the vasomotor system, which actually will cause an increase to the blood pressure. You guys learned about blood pressure, how to obtain a blood pressure in fundamentals. So when we think of elderly patients or gerontology considerations in the cardiac system, we have to think about, and you guys have a table 32-1 on page 691 that looks at the chest wall, the heart, and the blood vessels, and the difference in assessment findings. So when we talk about the chest wall, you may have altered chest landmarks for palpitation, percussion, and you may have a distance in the heart sounds. So the heart sounds themselves actually sound off in the distance. A lot of times if you have a patient with CHF or an enlarged heart, which can be found in the elderly population, their heart sounds sound kind of muffled or off in the distance. They're not quite as loud and clear as if you were listening to a 20-year-old. The other thing with the heart is you can have a decrease in cardiac reserve. They can also have a systolic murmur, which could be an aortic or a mitral valve. And this is actually possible without any kind of indication or history of cardiac disease. As far as the blood vessels go, they usually have an increase in their systolic blood pressure. They may have an increase or a decrease in the diastolic. They usually have a widening pulse pressure. Pedal pulses are typically diminished because the circulation and perfusion is slowed down as we age or get older. They usually have inflamed or painful cord-like viscosities, and they usually have some type of dependent edema.